ladder for. So earlier concept was that when we are following the WHO ladder, level 1, 2, 3, we have to follow. And if still patient is not getting relief in pain, then we move on to interventions. But that is no longer true. And interventions can be offered at any level of the WHO ladder if the patients are in pain. So what is sympathetically mediated cancer pain? Of course, we know that cancer pain can be associated with over or under activation of the sympathetic nervous system, and there will be some sympathetic dependent pain or sympathetic maintained pain in cancer. It can be characterized by cutaneous dysesthesias. It can be like a burning, throbbing sensation. Allodynia can be there. Hyperpathia can be there. Even signs like excessive sweating and vasoconstriction could be there, which indicate that this pain has a sympathetic component. Some situations in which we can sympathetically mediated cancer pain could be post-surgery, like radical neck dissections, or post any nerve damage that can happen. The nerve damage can happen by the tumor itself, or it can happen after thoracotomy or post-mastectomy pain syndromes, as we see in CA breast patients. It can happen after limb amputation. Patients like lymphoma, leukemia, they are immunocompromised. They can develop a post-herpetic neuralgia. There can be a number of visceral pain syndromes. So a large component or a large bulk of cancer pain is a sympathetically mediated cancer pain. Now, these are some of the examples of cancer pain. As you can see in this lady, it is a post-herpetic neuralgia. Here it is a tumor growing out. This over here is more of a vascular pain situation, but nonetheless, these are some of the examples of sympathetic pain. And of course, visceral pain is also an example of sympathetically mediated pain. So, what do we know about the sympathetic nervous system? So, to be honest, coming 2-3 slides are complicated and they are all about the anatomy of the sympathetic nervous system. It's okay to be a little bit confused in that because it is complicated, and for me also I have to refer to it again when I'm trying to understand the anatomy, because it is a complex system and this is a schematic representation of the sympathetic system. The important 2-3 things to remember are that it is, number one, it is a thoracolumbar outflow. So that means the sympathetic fibers exit the spinal cord from somewhere between T1 to L2. That is the region where the sympathetic fibers are exiting the spinal cord, and then they join the paravertebral sympathetic chains. Number one. Number two, there is a lot of crisscross of the fibers. That means that it's not that the same level fiber will supply the same level. These fibers, they go up and down a lot, and they go to the contralateral side also a lot. So there's a lot of overlap to the other side and cranially and caudally as well. Now, if we try to understand the thoracolumbar outflow exactly, like I told you, anywhere from T1 to L2, somewhere it is written L4 also, these sympathetic fibers eventually exit from the from the spinal cord, and then they all come and join together at the paravertebral sympathetic chains. There are a number of sympathetic ganglions, starting from cranial cervical ganglion, middle cervical ganglion, cervicothoracic ganglion, then the whole sympathetic trunk, which has a thoracic component and a lumbar component. Then when we come near the abdomen, there is a celiac ganglion, which is mediating the pain of the upper abdominal area. Going further down, there is a pelvic plexus. There is a superior hypogastric plexus actually. Superior and inferior hypogastric plexuses, which are mediating the pain of the pelvis. And then finally, it terminates into the ganglion impar, which is the last ganglion of the sympathetic chain. Another diagram demonstrating the same as to how the sympathetic chain connects with the dorsal root ganglion. It is via these gray and white rami communicans fibers. But when we are talking about blocking sympathetic fibers in a cancer pain situation, we are usually talking about targeting this. Somebody is doing Aarti. Please, could you mute? Yeah, thank you. So what I was saying was that when we are talking about blocking the sympathetic chain in a cancer situation, we are talking about our targets in this chain, in this sympathetic chain, which lies close to the dorsal uh, roots. Again, more diagrams showing us the same. Here, important to learn this one because based on the site of lesion, it tells us what is a potential sympathetic ganglion that can be blocked. So if the site of the lesion is anywhere in the nasal mucosa, palate, or tongue, we usually think of blocking the sphenopalatine ganglion. If it is in the eye, parotid, thyroid, or larynx, stellate ganglion can be considered. For the upper extremity, again, anything between either a stellate ganglion or a thoracic sympathetic block can be considered. For the pain in mediastinum and trachea, the thoracic sympathetic block is the one that needs to be done. Upper abdomen, all of it, starting from the distal esophagus, stomach, gallbladder, liver, pancreas, small intestine, large intestine, upper ureter, kidney, all this would be covered by the celiac plexus or the splanchnic nerves that we can block. Adrenals also, mostly by the celiac plexus, or there may be an overlap from the lumbar sympathetic system. Lower extremity, mostly lumbar sympathetic system or block. Then all this in the pelvis, ovary, testis, epididymis, prostate, usually responding to superior hypogastric plexus block. Bladder also usually responding to superior hypogastric plexus block. There may be some overlap from the lumbar sympathetic block. The lower intestine, large intestine, uterus, proximal vagina, all superior hypogastric plexus. And then coming down to the absolute perineal area, like the distal vagina, rectum, distal urethra, and perineum, that is the one that is covered by the ganglion impart block. So as you can see, the list of plexuses on the right side, these are the ones that we can target in practice to address sympathetically mediated cancer pain. Now, one of the topics to be discussed today was how to block these sympathetic ganglia. Should we do a chemical neurolysis or should we do a thermal neurolysis? Thermal neurolysis means an RFA. So as we know, whenever we are doing any block, if we are going to give the patient local anesthesia and steroid, the effect usually stays for 3 to 6 weeks. If we are going to do an alcohol neurolysis, the usual duration is 3 to 6 months. And if we do an RFA or radiofrequency ablation, standard RFA that is, then the duration is anywhere between 9 to 12 months. How do we decide? First of all, let's understand a little bit about the neurolytic agents that are available. Alcohol and phenol are the ones which are most commonly used. In my practice, I'm mostly using alcohol. Phenol comes as a powder and it needs to be reconstituted and used immediately. So alcohol, the mechanism of action of alcohol is lipid extraction and protein precipitation. Phenol works by protein coagulation. It's important to remember these percentages of alcohol and phenol which are effective. So alcohol is effective in a percentage anywhere between 50 to 100%. If you use less than 50% alcohol, it will not be a neurolytic agent. Phenol, it is somewhere between 5 to 10%. Usually 6% phenol is the one that is used. Now, there is a column here about density relative to the CSF. This is important if we are considering intrathecal neurolysis. Because if we are giving alcohol, we would want the target site to be upper because alcohol is hypobaric, so it will go up. Vis-a-vis, if we are using phenol, then we would want our target site to be lower because phenol is hyperbaric. Diluent, like I told you, alcohol itself is a liquid. Phenol is often reconstituted in glycerine. Alcohol, if you are injecting, it is painful, yes. Phenol is not painful because phenol in low concentrations and initially has a local anesthetic property itself. So injection of alcohol is painful, but phenol is not painful. Onset of alcohol is usually instant, and within 3 to 5 days, you will know the complete effect. Phenol is quicker. Within 15 minutes, it will start working, and in 1 day, you will know the effect. But then, at the cost of the effect remaining there only for about 4 to 12 weeks. Vis-a-vis alcohol, it has a longer clinical duration of action. So this is a comparative chart or comparative table showing us what to choose between alcohol and phenol. It basically depends upon availability, to be honest. Whichever chemical agent you have, neurolytic agent, you can use in your practice, but you should know the concentrations which should be used, and you should know when it will start acting and how long the effect will last. In most practices in India, it is alcohol that is used. Versus, of course, the option of thermal radiofrequency ablation is always there. Most of you throughout the year must have now become familiar with the radiofrequency lesion generator system. There are 3 types of radiofrequencies that can be done: pulsed, continuous, or cooled. We'll come to the cooled in the next slide. So as you all know, in continuous RFA, we usually give a higher temperature, typically 80 degrees Celsius, 90 seconds, 2 to 3 lesions each side. For pulsed RFA, it is usually a lower temperature, and it is more of a neuromodulatory mechanism. So if choosing an RFA for our patients, we do pulsed RFA if our target is a mixed nerve. So if our target is a mixed nerve, for example, if it is a suprascapular nerve, or if it is the glossopharyngeal nerve and it has a motor component, then we prefer to do a pulsed RFA. In a sympathetic block, we can go ahead and do a continuous RFA because there is no motor component of the sympathetic ganglia that we are trying to block. Cooled RFA, of course, has applications in chronic pain. In cancer pain situations, I would not recommend using a cooled RFA technique because whatever targets you are going to, or whatever, at least the sympathetic targets that you are going to, they are present close to a lot of sensitive structures in their vicinity, and we will not be safe using a cooled RFA in sympathetic blocks in cancer. So this is not to be done. This, of course, you know that the size of the cooled RFA lesion is much bigger than a standard RFA lesion. So this is an advantage in some places, like, for example, the knee genicular nerve block, but this is a disadvantage in cancer sympathetic blocks. So not to be done. Now, of course, before going ahead for any cancer pain intervention, a number of other factors need to be considered, including these guidelines for anticoagulants and antiplatelets, for which you have to remember to stop the various antiplatelet or anticoagulant medications before their respective days. So for clopidogrel, it is 7 days, apixaban, rivaroxaban 3 to 5 days, warfarin 5 days, and IV heparin for 4 hours. Let me know if there are any doubts or if you want me to go slower or faster or anything. Is everybody following so far?
Yes, ma'am.
Okay. So I'll continue. So, like we are discussing, sympathetic blocks can be diagnostic, prognostic, and therapeutic. So they can be diagnostic to determine, first of all, if the patient is having some kind of pain, maybe a head and neck pain. We have to determine whether or not that pain is sympathetically mediated or not. So you can just give a small dose of local anesthetic and check the response to that block. Prognostic, of course, it comes as this under the same heading actually, to determine if neurolysis or RFA would be beneficial. So if a simple dose of a local anesthetic is giving good relief, then that means that a neurolysis or an RFA would be beneficial for pain relief in this patient. And therapeutic, of course, because we have to provide reduction in pain and thereby functional restoration to the patient as far as possible. So now these are the basic principles of sympathetic nerve blockade in cancer. Now I will be talking about the various targets for cancer pain relief in that we had just enumerated before. So for head and neck, the two most common sympathetic ganglia or nerves that we block are the sphenopalatine ganglion and the stellate ganglion. For the thoracic area, the two most common are T2, T3 sympathetic block or splanchnic nerve block. For the lumbar, in the lumbar area, the most common ones are celiac plexus block and lumbar sympathetic block. And for the pelvic area and perineal area, the most common ones are hypogastric plexus block and ganglion impart block. So I just want to understand before proceeding, do you all have you all done any of these blocks? Has anybody done any of these blocks before? Or are we all very new to the concept?
No, we have not done it.
Nobody has done. Okay. Have you read about these previously?
We
Yes,
have
ma'am.
done, ma'am.
Yes, ma'am.
So you have read about these, you are familiar with the theory of these, but you've not done them in practice. Okay. And
Yes.
but because you've been a part of this program since a year, you've been attending lectures, so you are familiar with fluoroscopic landmarks and ultrasound landmarks, right?
Yes, ma'am.
So you are familiar with those. You are familiar with fluoroscopic pictures and ultrasound pictures and landmarks for various nerve blocks, right?
Yes, ma'am.
Okay, so I will explain based on that, because I have mainly included pictures for a better understanding. Learning each block itself is a big chapter and a big lecture. So we'll just be touching upon the important points for all. Okay, so first we are talking about the sphenopalatine ganglion block. Head and neck, complex anatomy, very, very complex anatomy. But if you remember this picture from the anatomy days, you will remember that the sphenopalatine ganglion lies in the pterygopalatine fossa over here. This is the pterygopalatine fossa. There are a bunch of other nerves. No need to remember names. You can't remember all the time. But this ganglion lies in the pterygopalatine fossa. And it is right lateral to the lateral wall of the nose. So the interesting thing here is that, first of all, I'll tell you the indications. So this ganglion can be targeted for sphenopalatine neuralgia, even trigeminal neuralgia cases, refractory headaches, atypical facial pains, and in cancer situations, cancer involving the tongue and floor of the mouth. Now, again, I will highlight this is the pterygopalatine fossa, and this is where the sphenopalatine ganglion is suspended. The interesting thing is that if you want to assess, if you want to do a diagnostic sphenopalatine ganglion block, you don't have to use any needle. It can be done by an intranasal technique using a cotton swab stick. So you just have to take a cotton swab stick, insert it into the nose near the middle turbinate lateral wall, and give the patient 4% viscous lignocaine. Dip this tip in 4% viscous lignocaine and keep it there. So by transmucosal absorption, because since the ganglion is lying right there, by transmucosal absorption, the sphenopalatine ganglion can be blocked, and within 30 to 60 minutes, you will know whether or not this ganglion block is going to help your patient or not. So this is the intranasal technique of sphenopalatine ganglion block, can be easily done in OPDs. Even on OPD basis, it can be done. If the patient gets good pain relief, you can go ahead and do more invasive interventions. The challenge often remains in head and neck malignancies when we are doing a sphenopalatine ganglion block. The challenge often remains that there can be a lot of anatomical variations, and it could be a post-surgery situation, it could be a post-radiation situation, there could be a new mass here. So there could be a flap or anything. So anatomy is usually distorted. So be very careful before proceeding for this block. However, if this is the target that needs to be done, then under fluoroscopy, we identify the infrazygomatic area, and we have to enter from between the two condyles of the mandible. So the first picture you see here is the picture of the skull on lateral view. And we are entering here between the two condyles of the mandible. This over here, if I'm able to point out, is an inverted vase. So we have to look for an inverted vase appearance. This is the pterygopalatine fossa. So our target is this inverted vase. And once we are in it on the lateral view, we check on AP view, the tip of the needle should be lateral to the lateral wall of the nose, lateral to the lateral wall of the maxillary sinus. So this is the needle tip position that we confirm, and only after confirmation on both lateral and AP views do we go ahead and give any injectate or do an RFA for the sphenopalatine ganglion. Coming to the next, stellate ganglion. Wait, before this, I'll tell you. So for sphenopalatine ganglion, because whenever, if we are trying to give a medication, we can always go ahead and give a local or a steroid. If it is helping the patient, and if you want to do an RFA, one thing to remember is that in these sensitive areas or in these small areas where there are a lot of other sensitive structures nearby, it is always useful to use a needle with an active tip of 5 millimeter. Do not use an active tip of a 10 millimeter. So this is how you decide. Be very careful about choosing your needle when doing RFA. And for procedures like these, you use active tip either 5 millimeter or sometimes even 2 millimeter. Now coming to the stellate ganglion block. Stellate ganglion is the next one that can be targeted for head and neck situations. Described way back by Chisagne. So you will remember that in anatomy, we used to learn C6 vertebra has a tubercle, which is called as the Chisagne's tubercle. And that serves as a landmark for performing the stellate ganglion block. So in 80% of the patients of the population, that is where this ganglion lies. That is at the Chisagne's tubercle of C6. But as you can see the anatomy, again, complex anatomy, lot of other sensitive structures nearby. The brachial plexus is right there. The right subclavian artery is right there. Lung is over there. One muscle to remember over here would be the longus colli. So this ganglion lies on top of the longus colli. So as you can see, a lot of sensitive structures. So we have to be very careful while performing the stellate ganglion block. It is indicated in, of course, a lot of pain syndromes and a lot of vascular insufficiency situations. Some important ones being CRPS, herpes zoster, orofacial pain, neuropathic pain, and a bunch of other indications. But here today we are talking focused on cancer situations or cancer pain. Before performing this block, because I showed you so many sensitive structures and other anatomical sensitive structures nearby, routine ASA monitoring is a must. IV line should be there in order to be prepared for any untoward event. And you have to take a proper history and rule out any risk situations before going ahead with the block. Now, how do we do the stellate ganglion block? There are 4 techniques described. One is the landmark technique, one is ultrasound guided, fluoroscopy guided, or CT guided. In practice, we are usually doing either ultrasound guided or fluoroscopy guided. Among these two also, USG is the one which is now propagated and promoted and encouraged because you can see all the structures under ultrasound guidance. Landmark technique is not to be done. Now that you have so many other techniques available, do not do landmark technique for stellate ganglion block. Fluoroscopy guided, of course, it can be done by identifying the C6 vertebra and identifying the oncovertebral joint. And just beneath the uncinate process of C6 is where we need to reach to perform the stellate ganglion block. This is what it looks like on fluoroscopic pictures. This is your target point and your anterior, of course, to the epidural space. The target is the base of the uncinate process. In the lateral view, you are in the retropharyngeal space anterior to the longus colli muscle. Again, this is easy to see in textbook images, not that easy to see on fluoroscope. So what is recommended is the ultrasound guided technique. In ultrasound, you'll be able to see everything very clearly. So if you're all practicing anesthesiologists, we are using ultrasound routinely for putting lines or doing a brachial plexus blocks. So if you scan in the same area, if you start from the midline scanning and you see the thyroid, you move laterally, and these are the structures that you're going to see at the level of C6. So C6 corresponds to the cricoid. So start scanning at the level of cricoid, move laterally, and you're going to see the trachea, you're going to see the thyroid, and then you're going to see the carotid artery and IJV. And right beneath the carotid artery is the stellate ganglion, which is present. It is lying on top of the muscle, on top of the longoscoli muscle, and this muscle is attached to C6. So you're going to see C6 and you're going to see a shadow over here, which is the Chassagn's tubercle of C6. So that is how you identify C6. If you get this image on your ultrasound, go ahead and you can do stellate ganglion block very safely. Again, more images showing us the same and showing us the target for stellate ganglion block. Now you can see this structure that you see here is the Chassagn's tubercle. CT guided stellate ganglion block can also be done, but then most commonly we are using ultrasound guided techniques these days to perform stellate ganglion block. Now, if your block is successful, you're going to see something called as the Horner syndrome, in which there'll be ptosis, meiosis, anhidrosis in ophthalmos. So before doing the block, you have to tell the patient that you may experience a temporary drooping of your eye, or you have to explain to them that it might happen, but it is usually reversible. Usually this gets reversed in 1 or 2 hours. Complications, needless to say, if you have a misplaced needle, you can damage anything nearby, which can be the carotid artery, IJV, inferior thyroid artery, vagus nerve, brachial plexus, pneumothorax, chylothorax, anything. But don't be so scared to do it, because if you're able to negotiate your needle in the correct position, nothing happens. Another thing is that if there is inadvertent spread of local anesthetic, then of course there can be associated complications. Sometimes patients will have hoarseness of voice because you have given too much volume of the medication, and now it has gone to the recurrent laryngeal nerve. Or you have caused a partial phrenic nerve block. So be careful about the volume of drug that you're using. Do not use more than 5 cc's or 5 ml of drug to be injected around the stellate ganglion. Now, sometimes what happens is that we are targeting this ganglion to block head and neck pain as well as upper limb pain. But in 20% of patients, the sympathetic fibers for the upper limb do not cross through the stellate ganglion. They bypass the stellate ganglion, and these are called as Kunz fibers. So in these 20% patients, even if you have done a perfect stellate ganglion block, you may not achieve good pain relief in the upper extremity. So for these patients, we have an approach by which we have to directly target the thoracic sympathetic fibers at the level of T2 and T3. This is also a commonly done procedure, especially patients with upper limb pain. Even I have done it in patients with CA breast with lymphedema, and it has helped them a lot. How is this T2, T3 sympathetic block done? For this, we have to work at the level of T2 and T3 vertebrae, and the sympathetic trunk lies on the lateral aspect of these vertebrae, and the landmark on fluoroscopy is the junction of posterior 1/3 and anterior 2/3 of the vertebra. So if you see, this is how it is described. It is at the junction of the posterior 1/3 and anterior 2/3 of the vertebra. That would be our endpoint on lateral view. So coming to the fluoroscopic pictures, this is T1, this is T2. T2, just underneath the rib, lateral to the vertebral body, we are entering. And same at the level of T3, we will enter. And on lateral view, this is where we have to be. This is the posterior 1/3 and anterior 2/3 of the vertebra, where we have to target our needle tip, and there we can go ahead and perform the procedure. In anterior view, the dye should be within the confines of the vertebral body. So you must have read this also. that if you're doing any sympathetic block, in AP view, the dye should be within the confines of the pedicle. If it is too much lateral, that means you're in the wrong position. More images showing us T2 and T3 sympathetic block. This is the tip in lateral view of the needles. Now, of course, since you're working in the thoracic region, it is important to stay within 4 centimeters of the spinous process. Otherwise, you may end up causing a pneumothorax. And another complication that can happen is because you're close to the ribs and you're close to the intercostal nerves, you may accidentally burn the intercostal nerves and cause intercostal neuritis. So be very careful. Always do proper sensory motor testing before performing a T2, T3 RFA. For at this level, RFA is usually preferable. Don't give alcohol or any other agent. Now, coming further down to splanchnic nerve block and celiac plexus block, we are discussing these together because they are both for upper abdominal pain. And we are essentially targeting the similar plexus for pain relief. Now, again, going back to anatomy, there are 3 splanchnic nerves, greater, lesser, and least. These 3 join together and they form the celiac ganglion. So we can either block the celiac ganglion, which is present in front of the aorta, or we can block these splanchnic nerves, which are present much behind the aorta in the retrocrural space. We'll understand that more in further diagrams. So as you can see, this is an anatomical dissection. Lateral view, posterior, anterior. These are the splanchnic nerves which are coming in front of, by the side of T11 and T12, and then they join together and then they come anteriorly and just around the celiac artery, they form the celiac plexus. Another diagram showing us the same. So instead of reaching so much anterior and instead of reaching the celiac artery, instead of going transaortic, that is one technique for performing the celiac plexus block. If you don't want to, or if there are any anatomical contraindications, or if the celiac artery is completely engulfed by the tumor in the upper abdominal area, better to stick to the retrocrural space and block these splanchnic nerves right over here. So when performing a celiac plexus block, we can give good volumes of alcohol, but when performing a splanchnic nerve block, it is better to do an RFA, which can be done at the level of T11. So this is how we target at the level of T11. Sometimes people do it at both levels, T11 and T12, but usually one level is enough. T11 is enough. And we reach these nerves in the anterior 1/3 of the vertebral body in lateral view, and we go ahead and burn them. Again, more diagrams showing us the same. Important to consider that celiac plexus is in front of the diaphragm and these splanchnic nerves are behind the diaphragm or in the retrocrural space. And retrocrural space is always safer when we are performing our block. Most common indication, like I already told you, upper abdominal malignancies for that. Okay. Now for these patients also, we have to have a wide 18 or 20 gauge IV line in situ, because when we do splanchnic blocks or celiac plexus blocks, patients can have hypotension. So it's better to have a wide bore cannula and it's better to preload them with 500 ml of balance all solution before doing the block. Now, when doing a splanchnic nerve block, we know the level that we have to do it at. It is T11. We have to take the C-arm in oblique view for tunnel placement of the needle. So this over here, as you can see, these are the fluoroscopic images. This is a left in this, for this particular picture, this is T11 and the fluoroscope is currently in oblique position. The needle has been inserted on end on. This is what it looks like. It has the same, it has to be done bilaterally. So needle has to be inserted from both sides of T11. And once you see the lateral view, the needle tip lies at the junction of, here it is in absolutely at the anterior margin of the vertebra. But even if you are at the junction of the anterior 1/3 and posterior 2/3, that is the correct place to be to perform splanchnic nerve block safely. This is the dye spread. In AP view, again, this is the dye spread. Like I told you, it is within the confines of the pedicle. We are safe, good to go. This is another diagram showing us the two needles which have been inserted from each side, the tip line at the level of anterior 1/3 and posterior 2/3 of the vertebra. Celiac plexus, like I told you, it is much more anterior. Can be done fluoroscopy guided, USG guided, CT guided, or EUS guided. This is how it looks like on fluoroscopic images. Again, so here, for transaortic approach, the needle is inserted at T12L1 level. And on lateral view, we have to go much ahead the anterior body and anterior margin of the vertebral body, and we have to go through the aorta through and through. And this is the kind of dye spread that we see. In my personal practice, I have stopped going transaortic for a celiac plexus block. Anterior USG technique can be done, but then again, a lot of anatomical structures on the way, so not very safe to do. CT guided procedures are also done, can be done in collaboration with your colleagues in intervention radiology. This can be done very nicely. And EOS guided celiac plexus block is also done. So some of our colleagues in gastroenterology have started doing it, but usually they don't give alcohol; they just give local and steroid. Complications, two main things to remember when performing splanchnic or celiac plexus block. Number one, hypotension that I told you. Patients might have hypotension, so be prepared to manage that. Preload the patient and be prepared to manage that. And number two, because we are cutting off the sympathetic supply, there is a parasympathetic overdrive. And because of that, the patients may develop some loose motions or hypermotility for the next 1 or 2 days. But usually it is self-resolving and it is not, you don't have to worry too much about it. You have to counsel your patients about it though. Splanchnic nerve block, because we are doing at T11, it is a thoracic area. So pneumothorax may happen, although very, very rare. Major complications can be many, but don't be afraid. Usually don't happen. They are very rare. Okay, we'll skip that. Is everybody following so far?
Yes, ma'am.
Yes, ma'am.
Is everybody following so far? Am I going too fast, too slow, too much information, too little information? Any feedback? Or should I continue the way I'm telling?
No, it's okay, ma'am.
It's
You
okay.
can continue.
Okay. So next, coming to the lumbar sympathetic plexus block. Lumbar sympathetic plexus lies on the anterolateral surface of the lumbar vertebrae. As you can see, that is the place where the entire sympathetic chain lies. Usually indications are for vascular diseases. So for me, in my practice, we are doing lumbar sympathetic plexus blocks more in patients with peripheral vascular disease and Berger's and diabetic gangrene and things like that. It also helps in CRPS type 1 and 2, multiple other situations. In a cancer situation, of course, if you have a lower limb pain or if you have an amputated limb which is hurting, it can be tried. The technique is we go at the level of the lumbar vertebrae, L2, L3, and L4. I'll tell you how the level is determined, but usually it is done at the level of L2, L3, or L4. We make our C-arm oblique, enter, and on lateral view, we have to reach the anterior border of the lumbar vertebra. Inject the dye, check, and go ahead and do the block. This is, again, more fluoroscopic images showing us AP view, oblique view. Oblique view is the one that we start with. So we have to make our C-arm oblique enough so that the transverse process gets buried within the body of the vertebra. So as you can see, this is the Scotty dog, and the nose is almost buried within the body of the vertebra. And then just at the lateral border of the lumbar vertebra, you can go in with your needle. And on lateral view, the dye is seen hugging the anterior border or the anterior margin of the lumbar vertebra. Now, how to decide so that in this particular patient, it has been done at all 3 levels. How to decide? This is decided based on where the pain is. L2 level is usually chosen if the pain is lumbar. L3 also if it is axial pain in spine. But Usually, if you're targeting the lower limb, then you have to do L4, L4 and L5 if you want to cover the entire lower limb area. Now, this image I have purposely added because I just wanted to highlight that here, the dye is not within the confines of the pedicles. It is going laterally. So in this picture, this dye is not at the level of the lumbar plexus. It is in fact in the psoas muscle. So this is a wrong picture. Now, when you're doing right things, you will also be doing wrong things. So it is all important to know that if you're getting this kind of dye spread, it is in the muscle and you're not in the correct position. You need to reposition your needle tip. Do not be outside the vertebra too much. Do not be away from the vertebra too much. Now, if you do this, most commonly patients could have a back pain. Sometimes the injection can go wrong, or there can be genitofemoral neuralgia if the neurolytic goes into a somatic nerve, because genitofemoral nerve is close by when you're doing a lumbar-sympathetic block. Moving down further to pelvic sympathetic blocks, like I told you, so there is the superior hypogastric plexus and inferior hypogastric plexus. We cannot block the inferior hypogastric plexus. We usually target and block the superior hypogastric plexus. Now, anatomically, it is located in front of L5S1. This is where the aorta bifurcates. So right in front of that bifurcation, this superior hypogastric plexus is present. Like I told you, anatomically, junction of L5 and S1. Again, it can be used for gynecological disorders, bladder-related problems, sympathetically mediated pain, chronic pelvic pain, and of course, malignancies in the pelvic area. The technique is, again, we have to go at L5S1 level. As you can see, the C-arm is oblique. Insert the needle. And you can go transdiscal also, or you can go paravertebral also. Essentially, on lateral view, this is what it looks like. Again, hugging the vertebral body, L5 and S1 level. These are other images showing us the correct needle placement and the dye spread, which is hugging the vertebral body at L5S1 level. And this is the AP view showing us the same. So once we have achieved this, we can go ahead and block the superior hypogastric plexus. Now, the last one in the list is the ganglion impar. Ganglion impar is the smallest midline single ganglion which is there for perineal pain. Probably one of the easier ones to do technically, because so this covers the whole perineum, distal rectum and anus, distal urethra, distal vagina, coccyx and scrotum. Of course, a useful block in coccydynia as well. So to perform this, again, start with your C-arm in lateral position. And as you do caudal epidural steroids, you will see that view. And just below that, you have to find the sacrococcygeal junction and just go in from there and deposit your drug. So this is what the sacrum looks like on lateral view when we are doing a caudal epidural. Now just beneath that, at the sacrococcygeal junction, just go in with your needle, deposit dye, check that you are behind the rectum. So this white shadow is the rectum. You don't have to puncture the rectum. Be very careful about that. And so here it is visualized better that the needle is going in and you stopped right here. This over here is bowel and rectum, not to puncture the posterior wall. Inject dye, check, and go ahead and do your block. Because the complications of this, the first is that is listed as rectum puncture and others. So I think I will end here. So I have listed most of the sympathetic nerve blocks that can be done in a cancer situation, depending on the area where the cancer is. I think if I tell you too much, you'll all be confused. This much is enough, but if you have any doubts, I'm happy to take any questions at the moment.
Ma'am, how do you dilute alcohol?
So usually, like I told you, what you'll get from the lab is absolute alcohol. So it is either 99% or 95% alcohol, right? So you don't have to dilute it less than 50%. You can make it a 75% solution and you can use it. You can even
You
use a 100% solution. So you can use it undiluted also.
you dilute it with local anesthetic or saline, no?
Better to dilute it with saline, but in my practice, so in injecting alcohol is going to be a painful process. So before you give alcohol through the needle, you have to give some amount of local anesthetic. Okay. So
Okay, ma'am.
I already give little bit of local anesthetic before. So I don't
Mhm.
dilute my alcohol in my syringe.
Okay.
Yeah. So the steps should be, once your needle is correctly placed, give local give lignocaine so that patients get that area becomes numb sooner. Okay.
Yes,
Give
ma'am.
lignocaine, wait for a while, give your absolute alcohol, undiluted if you want. And then after giving alcohol, never pull out the needle immediately. Always flush it with a little bit of normal saline and then pull it out. Otherwise, there will be a tract. A tract would,
Yes, ma'am.
a fistula could be formed.
Yes, ma'am.
Yeah. So those are the steps that should be followed.
And the steroid, ma'am, in the end? Or
Not necessary. In case of
okay.
alcohol ablation, steroid is not necessary. In case of RFA, yes, steroid is necessary.
Okay. Thank you.
Ma'am, I have a question.
Yes, please.
Ma'am, since there is a lot of overlap between the supplies, because we all know that it is a continuous chain. So,
Yes.
ma'am, if we talk about the lower abdomen, like say the pelvic structures and the perineal structures, they are supplied by the superior hypogastric. There are few structures which are being supplied by the superior hypogastric as well as by the ganglion impar. So, ma'am, how do you decide that which one should we go ahead? That we know that if it is sick, like the coccydynia, we normally give ganglion impart, that is fine. But
Yes.
what about the other structures, ma'am, which have common supply?
So, very good question and very correctly brought up by you, because the answer to this question is do both. So sometimes when we are managing sympathetically mediated cancer pain, we have to target more than one target.
Yes.
Hello?
Yes, madam, you are audible.
Yeah, I'm on. No, there was some disturbance.
Yeah.
So to answer your question, in practice, do both. That cancer patient will not be able to come to you again and again for different diagnostic and different therapeutic procedures.
I
So do,
request one to please, if you can put yourself on mute if you are not.
yeah, who is
Yes. Ma'am, there are two questions. What percentage of local anesthetic is used in steroid ganglion block?
what percentage of? Sorry,
Local anesthetic is used in steroid ganglion block by Gaurav Sharma.
what percentage of local anesthetic?
Yeah.
So I usually use, if you're using a local anesthetic, I usually use this thing. I mix lignocaine and bupivacaine. So ultimately it becomes 1% lignocaine and 0.125% bupivacaine.
Okay. There is another question, madam. What volume of drug are we injecting for superior hypogastric block on each side?
Superior hypogastric 10 ml. Total 10 ml is enough. Yeah.
So 10 ml each or 5 ml, 5 ml?
5 ml, 5 ml is enough. You can go ahead and give a little 8 ml, 8 ml also you can give.
Okay.
Usually that is enough.
Ma'am, I have one question regarding pudendal neuralgia
Yes.
and the ganglion impart. Ma'am, do
Yes.
we need to give both of them at the same time if we are confused that which one, like exactly what exactly the presentation of the patient is?
Yeah, that is what I'm saying. So that is what I'm saying. So pudendal nerve we didn't discuss today because it is not a sympathetic nerve. But yes, if you feel that your patient will benefit from both, go ahead and do both, because again, I will say cancer patient will not be able to come to you again and again for an intervention. So although in textbooks we have the luxury of understanding that, okay, first we will do a diagnostic and then we will do another diagnostic and then we will do a therapeutic for the patient. In practically speaking, it's not possible.
Okay, thank you, ma'am. Thank you so much.
Any questions?
Any questions?
Varsha, you there?
Ma'am, what if we puncture the rectum in case of, I mean, we are giving ganglion impart block, ma'am? What precautions do we need to take after that, ma'am?
You have to be very careful about advancing the needle. The whole idea is don't puncture. So
Okay, ma'am.
yeah, but okay, but I will answer that question. So in the subgroup of patients that you are doing the procedure in, they may be CA rectum cases, okay, in cancer situations. If it's a coccydynia, then you cannot puncture the rectal wall because that patient otherwise has no other anatomical problem over there. Okay. If the indication is a CA rectum, it is possible that the patient already has undergone a surgery or an APR, and the patient has a stoma from where all the like he's using the stoma, and it is possible that the for that patient that part of the rectum is now not functional. So you will still get away with it. But in case there is nothing like that, you avoid puncturing the rectal wall. Even if you do not give alcohol or do not do RFA, do not give alcohol. At best, maximum you can do is you can give a local steroid and come out.
Thank you, ma'am. Thank you.
If you give alcohol, you will burn it more. So the posterior rectal wall will be completely burnt. So don't do that.
Okay, ma'am.
Any more questions?
Ma'am, is there any chances of discitis in especially transdiscal approach in hypogastric plexus blocks
Yes.
with alcohol?
Yes. That is why if you're doing transdiscal, always give antibiotic before doing a transdiscal procedure, number one. Number two, if you're giving transdiscal alcohol or if you're giving alcohol anywhere, do not pull out your needle immediately after injecting alcohol. That is wrong practice because some of it will trickle onto in your path when you're bringing the needle out, and it can cause huge problems. So after giving alcohol, always flush the needle with saline or a local anesthetic and then take the needle out.
Thank you.
Any queries?
Questions, anybody else?
I think not.
Ma'am, you told around 3 levels for the lumbar sympathetic block, and in which condition we are going to use for at 3 levels, ma'am?
Usually 2 are enough. Usually we do at L3 and L4 and that is enough.
Is there any particular indication apart from single level, especially?
Oh, usually we end up choosing lumbar sympathetic plexus block for lower limb pathology pain and lower limb vascular pain, and it is better to do at L3 and L4 both.
Thank you.
Good. Any more questions?
Excuse me, sir. If foot and sole involvement is there, we give L4 level at L4
Yes.
level. No?
Yes. Yes.
Good. Any more questions? Prakash or Varsha, you there? Anyways, hello, madam. Good evening. I'm Dr. Kashinath Vangar.
Hello, sir. Hello.
Wonderful presentation.
Thank you.
And very nice question and answer. Very nicely covered. Very promptly covered. Precisely covered.
I hope this was beneficial, and I try to keep it short because if I just try to keep focus on the relevant points, otherwise there's a lot to learn in all of these blocks individually, and there's a lot to learn about alcohol versus RFA also, so that you learn while during practice. But this was my goal, was to give you a kind of an overview that these are the possibilities and keep them in mind when you have patients so that you can offer it to them.
Yes. Thank you, madam. Thank you. It was a wonderful lecture. And from the team IAPM, I thank you once more time. Such a wonderful presentation. Definitely, the students will, get benefit out of this.
Thank you very much for those kind words.
Thank you, madam. Thank you for your time again. And
So, and my apologies, I had to reschedule for today because last time I had some commitment, and today I know tomorrow is Dussehra, so I'm ruining your holiday. But thank you very
no,
much.
no, no, madam. It was wonderful. That's absolutely fantastic. This is an academics is more important than anything else. So thank you very much for your time.
Thank you.
Okay, man. Thank you, madam. Chalo, bye. Good
Thank you,
night.
ma'am.
Nice. Good night.
Yeah,
Bye.
yeah.